Hello, my name is Babatunde Ogunboshi. I'm a pediatric infectious disease specialist at the University of Ibadan, and I also work at the University College Hospital, Ibadan. Today we'll be talking about antimicrobial stewardship interventions and resources needed for its successful implementation. So we'll be looking at these basic items in the course of this talk. One, we'll be defining what antimicrobial stewardship is. We're going to learn about the different types of interventions involved in antimicrobial stewardship. We're also going to look at the triggers and resources needed for a successful stewardship program, and also understand the limitations and challenges of these interventions and how to develop an action plan. So the various drivers for antimicrobial resistance, which we all know is a global threat. In fact, in 2020, one of the top 10 threats to human health was antimicrobial resistance, and this threat and burden is increasing. Various factors have been alluded to play roles in antimicrobial resistance. But top of this, both in magnitude and the effect, is human antimicrobial misuse or abuse, or whichever you want to call it. The other important one that we often are oblivious or don't pay attention to is antimicrobial use and abuse in animal sector. Of course, other factors that play include healthcare transmission, often of drug-resistant organisms, suboptimal use of diagnostics, poor vaccination programs that expose people to infections and they get infected and leading to the need to prescribe antibiotics, dosing issues, and of course, mass drug administration in human health. And travel has also played a role, because these resistant bugs really don't recognize or respect boundaries. And so global travel has also played a role in antimicrobial resistance globally. But top of this still remains how we as human beings use antimicrobials, especially antibiotics. And that's why the issue of antimicrobial stewardship has become topical in our attempt to curb this challenge of antimicrobial resistance. So what exactly is antimicrobial stewardship? There are lots of definitions out there. So some would say that it's a set of coordinated strategies to improve the use of antimicrobial medications, basically with the goal of enhancing improved patient outcomes. And typically you want to set to reduce resistance to antibiotics or antimicrobials, and most times reduce unnecessary cost. In a clinical setting, we'll talk about the right antibiotic for the right patient at the right time through the right dose, the right route, and causing the least harm to the patient and also collateral harm or future harm to other patients. There's a definition I kind of like, and that definition talks about a coherent set of actions that leads to responsible use of antibiotics. So when we talk about antimicrobial stewardship, we're looking at sets of actions that are interwoven, but they're also sequential and ordered in a way towards a targeted outcome. And bottom line for all those actions just speaks to the need for us to be responsible the way we use antibiotics. And that can come to play in different settings, be it in hospital settings, individual settings, community, countries, or even globally. So we all have different roles to play when it comes to antimicrobial stewardship. But this today we'll be talking more about antimicrobial stewardship in the clinical care setting. Now, for you to have a successful antimicrobial stewardship program, there's some core elements that have been found to be fundamental to the success of antimicrobial stewardship program. On top of this is leadership commitment, because typically in antimicrobial stewardship program, you would involve or you engage multidisciplinary specialties in a hospital setting. You're going to engage or draw resources from multiple places, and there's definitely going to be a need for sustainability. And so the leadership commitment is actually key to the success of any antimicrobial stewardship program. There's also a need for accountability and responsibility, and taking responsibility for actions that need to take place. And so that again feeds both to leadership and to the led community or the society where the stewardship is taking place. And then of course we have antimicrobial stewardship actions or interventions, which we're going to be talking about today. And interwoven with all those actions and the strategic goals or objectives of that particular institution, we include things like education and training, which forms part of the bedrock for a successful stewardship program. a need for monitoring and surveillance, because anything you don't measure really you can't speak on its successfulness or otherwise. And then a need for reporting and giving feedback to settings where these interventions take place. Because with proper feedbacks, then people are either motivated or otherwise. So when they get feedbacks, then they get to do the needful, they get to have a buy-in and they kind of support whatever you're doing. But when there's no feedback, then you have challenges. And so you can have problems or challenges with stewardship program when there's a deficit in any of these areas where we've discussed. So when there's a lack of leadership and commitment, then you have challenges with drawing resources or getting various actors or players in the antimicrobial stewardship program doing the needful or being held responsible, accountable for what they ought to do. And then, of course, if there are no specific or well-coordinated stewardship actions, then you have challenges. Of course, when people lack requisite knowledge to take some required action, then you can't hold them accountable, and it's not just going to happen. And then I've spoken earlier about the need for providing feedback, and definitely you can't overemphasize the importance of monitoring what you're doing, and that would also definitely include things like surveillance to check trends and patterns of resistance profiles in that particular setting, and also consumption of particular classes of antibiotics in general, because as we said, misuse or abuse of antibiotics are one of the biggest drivers of antimicrobial resistance. And so if you monitor the use of antibiotics, then it's going to give you an inkling as to the impact of intervention. Now, where can antimicrobial stewardship be done in the hospital? Like I said earlier, you can do stewardship at different levels in the society, but we're talking more at the clinical setting today. And so where in this clinical setting can stewardship take place in the hospital environment? Of course, as you would imagine, most antibiotics are given on the ward, so you naturally have antibiotic stewardship activities on the wards. The laboratories interestingly play a very important role also in stewardship activities, and some of those we'll be alluding to. Quickly put, one of them is surveillance, for example. I mean, how do you do surveillance for resistant bugs without the microbiology laboratory supporting you? So the labs, you can do surveillance in the labs to follow trends of particular resistant organisms. In the outpatient or emergency setting, so they're very important. They share some similarities because oftentimes you have short-stay patients, and for the outpatient, people might wonder, how do you monitor antimicrobial stewardship in that setting? But we're looking at that and what activities you can do in that setting. And then, of course, the pharmacy. So we've talked about misuse or abuse of antibiotics, and so a good pharmacy is one place that can give you an idea of the volume and the pattern of antibiotic use, which you can use to monitor the effectiveness or otherwise of your interventions. Now, what are the key steps or processes involved in setting up an antimicrobial stewardship program in a facility? So the first and most important thing is to understand the setting where you are playing. So what are the key properties or resources or elements in that particular setting? And talking about antimicrobial stewardship in a clinical setting, you can have a stewardship program in a primary healthcare setting, in a secondary healthcare setting, or in a tertiary healthcare setting. And obviously, you would imagine that the kind of stewardship activities or structures you put in place in those different settings would vary based on the kind of patients they see and the resources available at those settings. So it's important to first have a baseline assessment of that facility to evaluate what the resources available in that setting, what their needs would be. And it might just be wise to do a SWOT analysis. So in a SWOT analysis, we're talking about looking at the strengths. So what are the things that are going for that environment? So do you have a keen executive, for example, that has even been talking about the need for using antibiotics properly before you even bring up a stewardship program? Do you have a setting where you have a vibrant continuing educational program where staff are brought up to speed and date with current practices and guidelines? I mean, those are kind of strengths you want to look at that exist in a facility. And the weaknesses are things that are inherent in that setting that might not make your interventions successful, and they need to be addressed. So, for example, if you have poor adherence of staff to guidelines and protocols, if it's a pattern in that setting, then that's something you probably need to address and reinforce. Then, of course, you need to look at what opportunities exist for you to harness or leverage on in deploying the different interventions that you want to deploy in that setting. And then definitely you want to assess the threats to whatever intervention you want to institute. And a common one that often comes up is attrition of staff, for example, where you train staff on stewardship, they get engaged and then they go out, or they leave the setting in very short time. So that tells you that you need to find a way to address that attrition or keep your staff from going. So it's important that every facility does a good assessment of where they are at before they delve into a stewardship program. The next and also very or probably more important structure to put in place is a governance structure. Because like I mentioned earlier, for you to do stewardship, you involve multidisciplinary settings. You're going to draw resources from multiple sectors and sites in that hospital facility. And the stewardship committee and the team need the backing of management to ensure that whatever actions or decisions are taken will be followed through. And so there has to be a very strong governance structure. And that governance structure will involve top management at the very most, and all those that are involved in policy decision in that setting. And then that would invariably be formed or considered into the Antimicrobial Stewardship Committee. And then underneath that, you have the Antimicrobial Stewardship team who are responsible for the everyday running of whatever activities that the Antimicrobial Stewardship Committee seeks to implement. Of course, below those structures might be different committees or subcommittees depending on the needs that the Stewardship Committee would realize or choose as action plans for that facility. Then, having understood the setting and put in place a governance structure to implement this program, the baseline assessment or the situation analysis will give you an idea of what will form the core elements of that particular setting and what their priorities would be. And next to that will be a need to identify the kind of stewardship interventions that will be deployed in that setting. And it's often advised that you start with some low-hanging fruits. And what do we mean by that? So some interventions don't need high-level resources or manpower or expertise. They often don't need a lot of processes to put in place and resources also. And so it's important, and they're also quite impactful and effective if properly deployed. And it's important to go for those, because once you get those and you deploy them and you see action, then you see impact, then it gives impetus to your intervention and support to whatever you want to do. And with respect to antimicrobial stewardship, one of those I often use as an example is formulary restriction, which we'll come to talk about in the course of this talk. And having decided all of this, then you need to draw up an action plan. Your action plan can be 3 months, 6 months, 1 year, 2 years, depending on the resources and the peculiarities of that setting. And of course, in that action plan will be a room or a place for revision as the need arises. And having done that, then the facility will go ahead and implement the stewardship interventions that have been agreed to. And of course, like I said earlier, you can't talk about the impact of anything if you don't evaluate. And so typically a monitoring and evaluation plan has to be put in place for any stewardship program. Now, when you look at antimicrobial stewardship interventions, there's some core strategies that form kind of the backbone of most intervention programs, and other supplementary activities that kind of augment what these core strategies are. And the core strategies would include prospective audit with intervention and feedback. We'll be talking more about that. Formulary restrictions and pre-authorization. And of course, the need for having a multidisciplinary team to carry out this intervention. The other supplementary strategies will include education, the need for developing guidelines and clinical pathways, antimicrobial focused interventions like streamlining or de-escalation or dose optimization, parenteral to oral switch, and the likes. So this will go into further detail as we go ahead. Now, with respect to core strategies, I think it's important to understand that this core strategy, like I said, have been found to have the greatest impact, and so it's important to focus on those, and having achieved them, you sustain them, and then you add on the supplemental strategies. I mean, oftentimes they don't stand alone. You typically over time, having established that, add other supplemental strategies. Now, one of the core strategies for antimicrobial stewardship program is the need to have a multidisciplinary antimicrobial stewardship team. Now, it's important to understand that in carrying out stewardship, it is not a one-man show, because various groups of professionals have various roles that they play in ensuring a successful stewardship program. So one of the important participants in the stewardship team would be the clinicians. And when I talk about the clinicians, typically we're looking at an infectious disease specialist or a clinical microbiologist that has good knowledge of infection syndromes and how to handle them, because that's really the core of antimicrobial stewardship. But beyond that, these specialists have to be skilled in interpersonal relationship and working with their colleagues and contemporaries, because oftentimes antimicrobial stewardship interventions will involve you delving into the management of other colleagues or doctors in the healthcare setting. And as we all know, in the ethics of the profession and by law, they typically have autonomy over the patient and they're ultimately responsible. So interventions is often a collaborative to ensure a good outcome for the patient and, of course, the care setting in general. Other important members of this committee would include somebody like the pharmacist, or if you have resources, a clinical pharmacologist. That will assist you in evaluating the different drug combinations that the patient is on, the dose, the route, the duration, and any other important things that's got to do with the process of drug administration. The nurses come very handy because they're often on the ward and they interact with different specialties that come to handle patients in the ward. And in some setting, really, the nurse might be the only resource that you have to lead this kind of intervention. And so the exposure and training and being part of this team are also very important. The epidemiologist or statistician and the IT specialists come handy because we've talked earlier about the need for monitoring and evaluation and also surveillance. So all those team members have a role to play. And then the clinical microbiologist or the microbiology scientist, because if you want to do surveillance on resistant patterns and trends, then you need the take or the input in ensuring a successful stewardship program. There's some bystanders when it comes to antibiotic stewardship program, because they're very important to the success of your stewardship program. And those will include the infection prevention and control team. Like we said earlier, part of the factors or drivers of antimicrobial resistance would be infection in general, especially in the healthcare setting. So it's important you have good liaison and interaction with the infection prevention and control team, such that in-hospital infection is reduced to the barest minimum, such that the need for more and stronger or high-end antibiotics is reduced. Now, like I mentioned earlier, when you talk about antimicrobial stewardship, you'll be delving into other people's domain or tuft or areas of practice. And so there's a need to have antimicrobial stewardship champions. The champions are probably one of your strongest allies when it comes to any program like this, be it in interacting with management, in interacting with colleagues in the healthcare space. And these champions will typically look at people that command the respect of the setting where you operate. So they can be very senior and revered clinical professors or consultants or personnel. They could be community leaders, maybe religious or cultural leaders, or even, as we have these days, social influencers, right? Be it in the entertainment industry or in settings where you know they can impact on people's behavioral patterns. So it's important in setting up your antimicrobial committee and teams that you look out for champions that you can run to. They're kind of the go-to people when you have challenges or you need to break a barrier. So they're not core members of the team, but they're integral members of a successful stewardship program. So let's talk a little bit more about some of the core interventions in antimicrobial or core strategies in antimicrobial stewardship. One of those is the prospective audit with intervention and feedback. This is one of the most widely practiced and, interestingly, one of the most rewarding because by its very nature, it brings the act of stewardship to where antibiotics are being used in an active manner. And to do a prospective audit, you typically need the engagement of the antimicrobial stewardship team with the primary managing team. And in talking about the primary managing team, we are referring to somebody that is senior enough in that managing team to take decisions when it comes to antibiotic use in that setting. So in a clinical setting, that will be a specialist or a consultant, as we call them, or even a senior registrar that is old enough or senior enough to take responsibility for that clinical setting. So it's typically a collaborative between the antimicrobial stewardship team and the primary managing team. And in that space where the prospective audit is taking place, there's some basic things that will be considered in that process. So most settings will have what they would call like a stewardship round, which will actually entail reviewing all patients on antibiotics, looking at the indicator for their antibiotic, the indicator antibiotic in question, and even the patient, which is the center for all these interventions. And to do this properly, you will typically require a treatment guideline or antibiotic formulary that's been agreed to by all the parties at play. And then, like I mentioned, this will entail an audit round. And that audit round will involve looking at each patient, looking at the presentation of the patient, looking at the antibiotic that has been chosen, the reason behind it, does it adhere to existing guidelines and formularies. You want to review the dose, the duration, the route. And of course, it also provides an opportunity for some form of diagnostic stewardship. So you'll be reviewing things like where necessary microbiological cultures taken before this stewardship, these antibiotics were instituted. Have those results come back and have them be used in the management of this patient? And like I mentioned, you'll be doing some degree of antimicrobial, anti-diagnostic stewardship. So you want to check, was this culture taken before antibiotics started? Were they taken in the right pattern or route? Did the cultures meet minimum standards with respect to transport to the lab, reception in the lab, duration of the pattern of processing, and even the turnaround time? Because all those could potentially impact on the results and the utility in the prescription of antibiotics. So you use this opportunity or this audit round, so to speak, to evaluate all of this. And in the audit round, you also want to pick up potential errors or adverse drug reactions that might need some adjustment to the treatment that the patient is having. And of course, some supplemental strategies would also be implemented at this round. So for example, you might consider recommending some parenteral oral switch. You might recommend some review of doses of the medications being given based on peculiar patients, based on patient peculiarities, for example, patients with renal failure or liver failure, if there's a need to do all these interventions. And very importantly is that these stewardship rounds provide a veritable setting for training and education. So you have the people that you want to influence or change their antibiotic prescription patterns right in front of you, and you can understand where they're coming from, the challenges, and make recommendations and share highlights or insights as to why those recommendations are the way they are. And in that case, it's now easier for them to adhere to adopt whatever interventions that you're talking to them about. So the prospective audit with intervention and feedback is very, very important and probably one of the cornerstones of a successful antimicrobial stewardship program. But again, the leads of this has to be somebody that is versatile in infection syndromes, understands antibiotics and how they use and the bugs, and different practices in that care setting. And of course, has a way and manner and skill with reaching out and bringing colleagues on board to do the needful. So I think I've talked about most of the advantages and disadvantages of this prospective audit and feedback, but just to provide more insight, I'd said earlier that it's one of the very important interventions that you can deploy And really, if it's done properly, it's easily accepted by clinicians because they see you bringing value to the care of the patients and improving outcome. And at the same time, because it's done as a collaborative, then they can maintain their autonomy as prescribers in the management of the patient. So it's often well welcomed if it's properly done. It also increases the visibility of the antimicrobial stewardship program and helps to form better cordial professional relationship, and even provide support for your stewardship program once people see the value added that you bring. Like I mentioned earlier, it provides higher opportunity for educational opportunities. The frequency, of course, can be tailored based to the need and the resources available. And it definitely oftentimes provides more sustained impact on improving prescription patterns and habits, and also provides an opportunity to review diagnostic stewardship like I mentioned. It sure has these advantages because at times it can be perceived as being intrusive when some colleagues kind of get their tough and don't want people to come to interfere in the way they manage the patients. No need to say again that it can be quite labor intensive because these activities are often add-ons to what the team members are already doing in their regular activities, so it can be a challenge. And the success, of course, is dependent on how feedback is communicated. So if feedbacks are communicated in a way that erodes on the autonomy and even the ego or the independence of the prescribers, then you have some backlash, and that can be quite unfortunate. Like I said earlier, the different review decisions that can take place in this stewardship round. So you can recommend a stop, for example, if there's no need to continue with such antibiotics. You might recommend a change from a broader spectrum to a narrow spectrum. You can recommend a switch, for example, to IV oral. And it's not all the time that you really want to de-escalate the kind of care or the level of care that the patient is receiving. At times you might have settings where you need to say, oh no, I think you need to go higher and escalate care. And it's important that all the interventions in this prospective audits are actually documented. So the decisions made at each setting, it's clearly indicated on the indications for this and what needs to be done, because there may be a need to review which of those has been followed through to understand how best to deploy your intervention. Another core strategy is formulary restriction and pre-authorization. So when we talk about formulary restriction, it basically just talks about the need to limit antibiotic available for prescription to some cadre of healthcare providers to a particular list. A very important list in this light would be the AWARE classification of the WHO, in which we have antibiotics that are classified under the access group, some under the watch group, and some under the restricted groups. So you typically want to emphasize or encourage access more, prescription of antibiotics more in the access group. And in this care facilities, then there might be a limitation to prescribing some antibiotics, for example, in the restricted groups. And then, of course, there's a pre-authorization in which there's a need for particular specialties or cadre of staff to authorize continued use of particular antibiotics based on the perceived need or utility in that care setting. It's important to understand that the stewardship committee would typically make decisions on which antibiotics will fall under this group, and this would go into the antibiotic formulary in that care setting. And the pharmacy, where you have a setting where most prescriptions and dispatch of antibiotics go through the pharmacy, will be in the know, and we kind of form like the guard and the implementer of this pre-authorization or formulary restriction intervention. Of course, it's also important to note that there will be methods and ways of getting back to prescribers where there's a need to get further authorization for some of these prescriptions when they do occur. So we typically would, like I said earlier, allow access to antibiotics in the access group, but there will be need for clearance before dispensing antibiotics in the watch group and the reserve group. This is kind of like a restrictive kind of intervention, so to speak, because the clinicians or the prescribers are restricted to do or act in a particular way. Now, this is not without its own challenges. It has advantages, but it's not without its own challenges, because there's the challenges of ethics of care. When do you stop a clinician or a healthcare provider from using what he thinks is the best interest of his patient? You need to strike a balance between the practice pattern of that particular clinician and the danger that that practice habit or pattern poses to the general popularity or general community. There's also the need to bear in mind that they might run the risk of having some medical legal issues if the necessary authorizations don't come through as at when needed, and that might pose danger to the health of the patient. Of course, in settings where there are no specialists on site to implement this, then it poses an obvious challenge. And of course, at times when this is not properly implemented, there might be delay in initiation of some critical therapy. But of course, I mean, this intervention comes very useful because it has advantages of preventing unnecessary and inappropriate initiation or use of antibiotics, especially the ones in the watch and reserve group. It ensures optimal adherence to guidelines that have been agreed to in that setting. And then it also prompts the review of the patient and indications for antibiotics, and also review diagnostic stewardship to see if the needful have been done before these antibiotics have been instituted. And like I mentioned, it's one of the low-hanging fruits that facilities can implement, because you really don't need a lot of resources to implement this. But that said, you need to understand the challenges or the dangers that are inherent, such that it does not jeopardize patient care. So some of the antibiotics that will typically fall under these restricted groups will be antibiotics that are used for multi-drug resistant organisms, like the methicillin-resistant Staphylococcus aureus, for example, or carbapenem-resistant gram-negative organisms. So antibiotics like colistin, like tigecycline, daptomycin. I mean, these are antibiotics that you typically would not use for the regular patient that comes through the ward service. And it's also important that this kind of antibiotics are flagged, because it tells you that there's a need for higher specialist attention or care in this particular case, which also helps to improve patient care and outcomes. So in the process of formulary restriction, it's kind of like a front-end approach in which front up there's already a decision made on what can be done and what can't be done. And also it provides an opportunity for calling attention for a review to a particular antibiotic prescription or utility process. Unlike the back-end strategy that you would want to call the prospective audit, in which the antibiotic prescription has already been made, the utilization has started and probably gone on for some time before the stewardship activity comes on. And then after a couple of days or thereabouts, you have a review of whatever has been done. And so some things might have gone on that ought to have been corrected earlier. So advantageous as it might be, it also has that downside that at times the boat might have been missed in some settings. And so there's a need to really look at the peculiarities of each setting and decide which is best and how to best deploy this in your particular clinical setting. So like I mentioned earlier, you typically want to start with the core strategies, and then additional strategies can be incorporated in the course of the stewardship program to further improve antimicrobial use in that clinical setting. And then we want to look at some of these supplemental strategies. So I mentioned earlier that education and training forms one of the core interventions for antimicrobial stewardship, and also happens to be one of the supplemental strategies. And this intervention is often persuasive, as you would imagine, because it basically involves providing information, but also interestingly forms one of the bedrocks of a successful and continuous antimicrobial stewardship program. So typically the education and training is led by the antimicrobial stewardship team based on the needs of that particular setting, and they'll typically provide the content of what these education and training facilities would involve, and they would provide training to various people in the healthcare space. So both those are involved with the IT end, the monitoring and evaluation, those that will use the data, the healthcare workers, whether they prescribe antibiotics or not, the hospital administration, the patients, to make them understand the importance of this intervention, the need for this intervention. They'll provide content as to what dangers antimicrobial resistance pose, the role of infection prevention and control in that particular care setting, what the stewardship program will be bringing on board, the advantages, the challenges, the resources that will be needed, the collaborators that would need to come to make this successful. And this education and training can take different forms. So it can be at induction programs, for example, when new interns come on board. So there might be a place to give them a talk on rational use of antibiotics. This can take place in regular continuing medical educational program of that care facility. It could be hospital-wide grand rounds, or could be clinical meetings in specific wards or units or specialties. And then we had mentioned earlier during the audit or antibiotic stewardship audit rounds. So in all those settings, you can provide education and training on antimicrobial stewardship in general and the different components of antimicrobial stewardship program. And of course, this can take different formats. It can be face-to-face interactions, can be online, can be modules that are hosted in the cloud for people to access and use, can be in form of print, text, or reference materials. And they are one of those activities of the stewardship program that should go on continuously and on a regular basis to reinforce whatever interventions you've chosen, to correct misconceptions and provide information on an ongoing basis. So like I said earlier, it is typically coordinated by the antimicrobial stewardship team, and they're better suited because they have a good idea of the care setting and what interventions or communication needs to happen per time. And it's also one of those interventions that have been found to improve the prescribing behaviors, because behaviors are driven by knowledge, and that's one of those things you want to provide in education and training. In education and training, really, it's also an opportunity to provide feedback on interventions, to know the things that are working and areas where there needs to be a revision. Of course, you would imagine that this is a lot of work, and like I said earlier, antimicrobial stewardship is an added job on most clinicians or most care providers in that care setting, so it can actually be quite a burden, but concerted and continued interest is important to make this successful. When you have few antimicrobial stewardship team members, then it becomes even a huge challenge. Guidelines and clinical pathways. So what exactly are guidelines and clinical pathways? So guidelines are written evidence-based recommendations on how to manage infectious disease syndromes or scenarios. And those evidence-based are often domesticated based on the realities or the peculiarities of that setting. And in developing those guidelines, you typically want to look at data from that setting, if available, and this might need to be revised from time to time. And like I said earlier, when you talk about data from that setting, that would include things like local antibiograms, which just speaks to the antibiotic susceptibility pattern or profile of common isolate organisms causing infectious syndromes in that setting. So you want to look at what is the pattern of the susceptibility profile to guide what recommendations you'll be making. But as we all know, in most developing countries, this is often a luxury or a rarity, and most settings will typically not have guidelines. But the good thing is there are existing essential medicine lists or standard treatment guidelines, whether national, international, or specialty-based, that can be adopted and adapted to that specific clinical setting. It's important to understand that in developing these guidelines or clinical pathways, the peculiarities of that setting has to be put into consideration, such that it speaks to the most common infectious disease syndromes in that setting, and addresses the peculiarities with respect to the availability of various antibiotics, the services available to manage those syndromes, and the buy-in of the users of those guidelines are also important. Challenges, it will typically require collaboration, and so there's a need for interactions with the people that will be using these guidelines. So most settings would employ a system where the people that want to use the guidelines will be the ones that would drop something based on what the challenges or what their needs are, and they get the input of specialists with antibiotic use to contribute to and improve that guideline, and a consensus is reached. So often you require collaboration. And beyond that, I mean, the utility of a guideline is how readily available, accessible, and knowledgeable the people that use it have access to it. So there has to be a widespread dissemination of these guidelines. So like I mentioned earlier, you typically want to employ a bottom-up approach, so you have better buy-in and adherence. You want to incorporate as much as possible local data, so it speaks to the peculiarities of that setting. And it's typically advised that you start with common infection or priority syndromes in that setting. So in pediatric setting, for example, you'll probably be looking at community-acquired bacterial pneumonia. In the ICU setting, you'll be looking at some hospital-acquired infections like ventilator-associated pneumonia, for example. And of course, these guidelines need to be reviewed from time to time. And in settings where the resources exist, then you might have electronic clinical decision tools where certain parameters are imputed, and it leads you to what next needs to be done to guide proper utilization of resources available, and antibiotics and diagnostic tools in particular in this case. So like I mentioned earlier, you can have local guidelines to those settings, or you might adopt national essential drug list or guidelines or standard treatment guidelines. And then these guidelines can focus on general antibiotic use settings like in surgical prophylaxis or in the pediatric emergency room, common conditions like community-acquired pneumonia. So now we want to talk about parenteral to oral conversion. So most patients that get into the hospital setting will need some form of parenteral therapy because they're quite ill, and that's why they've come into the hospital setting. And in such cases, you want to start antibiotics either via the intravenous route or the intramuscular route. But really, in actual fact, they don't need to complete the medication from that route, and so there's a need to revise or review the antibiotics that are being given. And it's important to understand this because the more you give parenteral therapy, the more pricking of the skin is, and also the risk of introduction of infectious agents. And also, once a patient is on IV or intravenous or intramuscular antibiotics, then the thoughts about discharge and continuation or discharge to the home setting is probably not thought of. And in such setting, there's generally increased risk to acquiring more bugs in the hospital setting. And the patient tends to stay longer in the hospital, increases cost of care, and a whole lot of not too good outcomes for that patient. And so it's always important to have your guidelines as to when to decide from an IV-IM to an oral switch. And that's part of what some interventions that a stewardship committee or program might want to deploy. So examples of this switch might entail, for example, in patients with community-acquired pneumonia. I mean, after 48 hours of antibiotics, really in most settings, the temperature drops to less than critical levels. So you want to change the patient to oral, and that done, then the patient can go home and continue monitoring from an outpatient basis. At times, the patient might not even be fit enough to go home, but might not necessarily need parenteral therapy. So take, for example, a child that has a pneumonia, is unconscious for some other cause, right? So you can stop your parenteral therapy and change to oral route and give via a nasogastric tube, for example. And of course, you need a good understanding of the pharmacokinetics and dynamics of these antibiotics to ensure or to be sure that the oral route is a potential option in that setting. That said, there's some medical conditions where you just need to complete therapy with a parenteral route, and that will include patients with osteomyelitis, for example, not necessarily complete, but give for a longer duration. But meningitis is one place, or infective endocarditis is one setting where you probably need to complete your therapy with parenteral route. So it's not all the time that you can actually institute an IV oral switch, but in most settings, you find that you really can institute such intervention. That said, it's not all the time really that you want to institute a switch to IV oral, and at times in some clinical setting you might actually recommend a reversal. So I think the whole essence in all of this is you need to look at the patient presentation, the clinical scenario, and the pattern of presentation or trends in the care of management of this patient to decide what is actually optimal or best for this patient. And like I said earlier, when you institute this parenteral oral switch, then you reduce unnecessary need for intravenous lines and complications. You reduce the length of hospital stay and even exposure to the hospital environment, which can pose challenge to the particular patient. So another supplementary strategy that we use in antimicrobial stewardship is really to streamline or de-escalate therapy. What does this mean? So most times in clinical setting, you will start antibiotics based on an empiric decision. You don't have the cultures to tell you this is the organism at play, but you have an idea of what organism might be causing this clinical syndrome and the clinical dissociative profile. So based on that, antibiotics are prescribed. But ideally, antibiotics, the culture should be taken before antibiotics are prescribed, and so it's expected that that decision is reviewed within 48, 72 hours, and so there might be a need to download to a narrow spectrum agent that causes less collateral damage and definitely lower risk profile or side effect profile, and definitely lower cost. That should be the ideal practice. So that's one of the kind of interventions that the stewardship committee might be undertaking. And at times you might not necessarily de-escalate, you actually at times can escalate based on the lab results. So basically this is just reviewing the initial empiric therapy and deciding what to do based on the results or clinical response that you've achieved. And it's important that in deploying this intervention, you ultimately want to reduce cost, and also you want to ensure targeted therapy to ensure that the least and narrowest spectrum of antibiotics are used. Unfortunately, when this doesn't happen, then you find out that patients can be on broad-spectrum antibiotics ad infinitum. Now, this is possible only when you have antimicrobial services with results that are assured and reliable, or you have the antibiotics that you want to de-escalate to. And when that is not available, then there's an obvious challenge with this kind of intervention. The other will be dose optimization, which I think I've talked about earlier. So different doses might apply to different clinical scenarios. So the weight of the patient, the presence or absence of chronic conditions like renal disease or liver diseases that affects the metabolism and the clearance of these antibiotics. So there's a need to revise dose along those lines. And in this, with respect to this, the clinical pharmacists or pharmacologists come as very useful resource where available. The advantages of this is that it reduces suboptimal doses and also the risk of adverse effects. For you to do this, you need patient-specific data with respect to the weight and the clinical conditions and the severity of those clinical conditions. And of course, you would also, in some settings, require microbiology results. So when these are not available, then it poses an obvious challenge. Combination therapy, yes, you would need that in some clinical settings, especially for difficult to treat or multi-drug resistant organisms. And so the stewardship committee during the rounds who are better suited to identify and review therapies that have been instituted for these particular groups of organisms. And it's important because when this is not done, then those organisms can continue to breed and spread in the care setting and worsen the already precarious antimicrobial resistance condition in that setting. Antimicrobial other forms. This is not common in most clinical settings in developing countries. And this speaks really to a dedicated antibiotic prescription form that details in clear terms the patient's biodata, the indication for the antibiotic, whether it's a community-acquired or hospital-acquired infection, whether it's a targeted therapy based on iron isolate that you've gotten from the lab with a specific profile to guide your therapy, or is an empiric therapy based on patient clinical presentation. It's also going to indicate the dose, the route, the interval, and when to stop or review this prescription. It basically provides a tool to strictly guide the utilization of antibiotics in the clinical setting. And you might choose to do hard copies or electronic formats if there's facilities for an electronic medical record. So this is quite useful because it can be used for interventions like pre-surgical prophylaxis, in which once these prescriptions are clearly stated, then nobody goes beyond that without further review of those prescriptions. The other advantage is that it can be used by nurses or even low-level healthcare providers, because the whole details for the indication or the utility of that, utilization of the antibiotics in that clinic setting is clearly stated, and they can follow those guidelines and ensure the needful is done. Like I mentioned earlier, it's not very common in most resource-constrained setting, and at times there might be a pushback from the facilities because that might entail extra cost, especially when hard copies of antibiotic prescription forms have to be printed. But it comes very useful, and this is just an example. It contains all the things I've mentioned earlier. You can take a closer look at it at your spare time. Now, we talked about, so far we've talked about interventions in the ward settings, that's admission settings on the wards or emergency room. But like I mentioned earlier at the beginning of this slide, we can have antimicrobial stewardship taking place in the outpatient setting. And so what activities can we do or can be carried out in the outpatient setting? Definitely education can take place, either with prescribers or group of prescribers, or interns or people that come for training in the outpatient setting. Then audits and feedbacks. So audits, for example, prescription audits or dispensing audits can take place in the clinical, in the outpatient setting. Stop orders definitely can also take place. So if a patient is prescribed a particular antibiotic for a certain duration, then the pharmacist, bear in mind the duration it ought to be taken for, and they can institute stop orders where necessary. Of course, clinical guidelines and pathways can also be utilized in the outpatient setting, in which case certain disease syndromes have peculiar guidelines or treatment modalities clearly stated out, and those that see patients in that setting need to adhere to it. Because the patients in this setting are quite mobile, the monitoring of these interventions can be challenging. But if the interventions are put in a deployed in a well-coordinated manner, monitoring really shouldn't be a problem. Another important resource that is needed for antimicrobial stewardship are some infrastructure, so to speak, right? Because I mentioned earlier that in every antimicrobial stewardship program, there's a need for monitoring and evaluation. And to do this properly, you need staffing that know and are equipped to do the needful. This staff need to be trained. So a facility that is deploying antimicrobial stewardship program, for example, needs to select its team, needs to build that team by providing them necessary knowledge and resource to do these activities properly. The presence of IT in that setting will definitely make your monitoring and evaluation very effective and easier, and so there might be a need to commit some resources for IT infrastructure. Also, there might be a need to provide resources to carry out regular evaluations on antibiotic use, for example, in conducting regular point prevalence survey to look at the pattern and the nature of antibiotic use in that setting. So these are some of the resources that might need to be put in place, and they might really require budget lines to keep them sustainable. And then the other thing is you might need resources, because we talked earlier also about audits and feedback, even with respect to education. So whatever the stewardship committee are doing or is doing needs to be committed back to the stakeholders, and so there's a need for providing platforms for disseminating antimicrobial stewardship activities. Of course, we've talked about surveillance in the laboratories, and so you need resources with respect to laboratory and IPC consumables, antibiotics, especially to avoid stockouts and ensure that whatever recommendations that you make are adhered to, data collection tools to support your stewardship program, and a couple of other resources that I imagine you would know or need in deploying stewardship successfully. Another important infrastructure is the microbiology laboratory, which is very, very critical in any successful antimicrobial stewardship program. Like I mentioned earlier, the microbiology lab plays a critical role in surveillance. So we expect that if stewardship is done properly, there should be a decline or a plateauing in the pattern of antimicrobial resistant profiles or patterns of budding in that setting. So there's a need to conduct surveillance on particular target isolates. The microbiology lab is relevant for that. We talked about developing local context-specific treatment guidelines, so they will help you develop antibiograms to provide targeted local evidence-based therapy for your antibiotics used in that setting. Because of the nature of these microorganisms and the need to interrogate the pattern of spread or evolution, then there might be a need to provide resources for molecular epidemiology to really study how these resistant profiles or patterns are coming up, or even in investigating outbreaks in that clinical setting. Then, of course, they also provide support to clinical staff to guide proper utilization and deployment of antibiotics in a clinical setting. Of course, this microbiology laboratory needs to provide quality assured lab results in a timely manner that can be used effectively for patient care. Unfortunately, this is often hampered by lack of funds and requisite personnel. In general, in most low and middle income countries, this is a very scarce resource, which is quite unfortunate. The other thing the microbiology laboratory can help do is to promote the use of access as against the watch or reserve group. So in this, how do I mean? So they might choose to do selective reporting of the antibiotics based on susceptibility profile that they come across, in which case they would typically report, where applicable, susceptibility profiles of antibiotics in the access group and kind of downplay or keep from the clinicians, those in the watch or reserve group, except there's a need to explore those possibilities, in which there now has to be a discussion between the two teams. Rapid diagnostic test kits are also another important utility when it comes to antimicrobial stewardship programs, because at times you see a patient that comes with a febrile syndrome, and the question is, does this patient have a bacterial infection or a viral infection, even a parasitic infection like malaria? And where typical diagnostic tools take time to come, the turnaround time is prolonged, then the rapid diagnostic test kits might come handy. However, the utility of this diagnostic tools will depend on the predictive values. When this is not very high, then you have a pushback and not good buy-in from clinician teams to use them in the managing of the patients. The other important rapid intervention tools will include diagnostic imaging facilities like ultrasound in evaluating or assessing for infection focus, especially in deep settings. I mean, they come typically quite useful. Unfortunately, these interventions will incur extra costs, and that makes them, unfortunately, not often widely accessible or available. Pharmacy and IT. So we've talked about antibiotic use and monitoring antibiotic use or improving antibiotic use. And it's expected that if stewardship activities are done the way they ought to, then there would over time be a reduction in the volume and the pattern of antibiotic use. And so the pharmacy comes very handy in guiding or monitoring the trends of the antibiotic that are used. Beyond looking at the volume and the pattern of use, they also are very useful in providing guidance as to the quality of antibiotic provided and used, because that again is going to impact on the success of your recommendations and your stewardship interventions. That said, and from all that we've said so far, whether it's from the clinical part of it or from the laboratory or the pharmacy, it's obvious that an IT infrastructure is central and key to successful evaluation and monitoring, and even at times in deploying stewardship intervention. We've talked about electronic medical record being used for pre-authorization, for example, or even stop orders, even in reporting lab results. So if you have a lab information system, then the turnaround time when it comes to reporting either ordering test results or microbiology tests, or even getting the results back, is reduced when you have a robust infrastructure to help facilitate this. And even carrying out audits or patterns of multi-drug resistant organisms or antibiotic use, once you have a good IT infrastructure in place, it makes this more seamless and probably easier to undertake. And then, of course, there is no need putting interventions in place without communicating to the care environment. And so an IT infrastructure that provides a platform for doing this is very important. In looking at the bigger picture, when a country wants to monitor antimicrobial resistance in its nation, when they are when there's a robust IT infrastructure in place, it makes gathering and sharing of this data quite easy. No, needless to say that this infrastructure usually expensive to deploy and at times entails quite some substantial cost to sustain. And so that's one of the challenges that might make the utilization of this intervention not readily available or possible. So we've talked a lot about different resources and that are needed for a successful antibiotic stewardship program. And I understand that, or we all know that resources are often in scarce quantity. I mean, they're not often always available. And like I mentioned earlier, the kind of stewardship intervention that you would adopt and deploy in your setting would be determined by the care setting, whether it's a primary, secondary, or tertiary setting. And this will also determine the kind of human resource or facilities that are available. And so when care providers find themselves in settings where resources are lacking, what should they do? The first thing I would say is that we all have to be innovative. We all have to be innovative in looking at what we want to do and how to get there. I mentioned earlier the need for example, task shifting. So take, for example, the antibiotic prescription guide or prescription document. If that's available, and you don't have doctors or ID physicians or microbiologists to do stewardship around, a tool like that can be deployed in a way that the nurses on the ward can now monitor antibiotic use. And then you find out that antibiotics are used in a more judicious pattern. Now we live in a virtual world, so to speak, thanks to COVID, right? So your stewardship rounds can even take place with an ID physician or a clinical microbiologist in a remote setting. They can join you virtually for your rounds, you know. So those are kind of interventions that people might want to consider in deploying antimicrobial stewardship in resource-constrained setting. So we looked at the persuasive and the restrictive kind of interventions, and I think we've dealt in depth on most of them. All right, so in the last couple of minutes, we've been talking about antimicrobial stewardship program interventions, the different interventions that you need to deploy, how to set out, how to plan it, and how to implement, and the different interventions that can be put in place. Like I said earlier, so these interventions need to be deployed in a very innovative and smart manner, depending on the care setting and the resources available. And I just want to say that no matter how simple or rudimentary that care setting is, there is one stewardship intervention that can be deployed. The bottom line, I think, is that we all have to think responsible use of antibiotics using the resources available to us.